And so I am going to talk to you guys about the management of neuropsychiatric symptoms in dementia. And I want it to actually be an interactive talk. I think we've got a small enough group that you guys can shout out questions or raise your hands and interrupt me so that this can be as useful as a talk as possible. And I am pressing the wrong. I have no disclosures. In terms of the talk itself, I'm going to start out by talking about the epidemiology of behavioral symptoms in patients with dementia, how to identify target behaviors in the context of your evaluation. We'll look at environmental and medical causes for these behaviors, non-pharmacological interventions, as well as a pharmacologic approach to managing the behaviors when that is needed. I'm hoping that by the end of the talk, you'll be able to distinguish agitation and aggression when either describing the behavioral symptoms or treating the behavioral symptoms, how to identify common reversible causes that might be precipitants for the behavior, and also to be able to describe the symptom-oriented approach for treating the behaviors in question. And my goal is that you'll ultimately be able to develop a plan for treating the problematic behaviors. So there are many types of dementias, and one possible way to categorize them is by etiology. Alzheimer's disease is the most common dementia that we see, affecting about 50 to 80% of patients. The focus of this talk is going to be on the management of behavioral symptoms in Alzheimer's disease, though I might from time to time specify the management of a non-Alzheimer's dementia throughout the lecture, but for the most part, I'm going to be referring to Alzheimer's disease. Vascular dementia is also very common and typically does co-occur with Alzheimer's disease, dementia with Lewy bodies, frontotemporal dementia, and then the secondary dementias. Regardless of the etiology, all dementias lead to a loss in intellectual abilities. They lead to impairment in judgment and decision making. They lead to a loss of executive function. They lead to personality changes. And those personality changes and behavioral symptoms we refer to as neuropsychiatric symptoms. They're very common. They affect up to 90% of patients with dementia. They're associated with faster rates of cognitive decline, earlier institutionalization, greater impairment in activities of daily living, and increased rates of caregiver depression. They are classifiable, which is what we'll talk about in the beginning of the lecture, and they're also treatable, which is how what we'll focus on toward the end of the lecture. This is a slide that looked at the prevalence of behavioral symptoms in patients and older adults with and without dementia. And what the authors found was that up to 60% of the patients in the 1 month before the study began, 60% of the patients had one or more behavioral symptoms, and that overall behavioral symptoms were 4 times more likely to occur in older adults with dementia than without dementia. So they are very, very common. This slide looks at the prevalence of behavioral symptoms in relation to the time of diagnosis. So you can see that the problematic behaviors, the really unsafe behaviors, do tend to occur in the later stages of the disease. And a lot of our talk will be focused on managing these behaviors because they can be so problematic and lead to either institutionalization or movement of a patient out of a care facility to an emergency room for evaluation. This is a roadmap that I use, and I'm going to come back to it. You'll see it from time to time throughout the lecture. I always start out by characterizing the target symptom. I need to know what the behavior is that I'm treating in order to treat it effectively. We're going to start out by talking about characterizing the behavioral symptoms. Once I have an idea of what the behavior is that I'm being asked to evaluate or treat, I look for possible medical causes of the behavior or environmental causes of the behavior, because if these are present, my focus becomes on treating those before moving on to add a medication or implement a particular behavioral intervention. So I really do need to know whether these factors are at play.
What's the number one environmental?
What's what?
The number one environmental problem that you've come up with.
I mean, we'll talk about a few. I think it's hard to say. I think it's hard to identify one that might be the most problematic. It really varies from patient to patient. What have you seen in the patients you take care of?
One, and it varies. It's said you know, that stimulation, overstimulated, noisy areas,
Yeah.
transition. So we're kind of looking at trying to find a common denominator of how to provide, you know, an adequate day or consistency with
Yeah.
that, and trying to figure out what, you know, one environmental factor is producing a problem.
Yeah, there's a lot of interpatient variability. We'll talk about some common environmental precipitants, and maybe we can use your patient as sort of a case example. Getting back to the target symptoms, before you can do anything in terms of an intervention, again, I can't stress enough how important it is to adequately characterize the behavior in question. Not only is it important to know what the behavior is, it's also important for you as a caregiver or for the treating health provider to understand the severity of the behavior and the frequency of the behavior. And I understand you guys got to talk earlier on the ABCs of behavioral evaluation. So that's important. That's an important part of understanding the nature and the frequency of the particular behaviors. And again, in order to do anything in terms of management, it is critical to know what the behavior is that we're being asked to treat. So I cannot stress that enough, that you got to be able to describe the behavior in question. Because again, any intervention that's going to be developed is going to depend on that particular behavior. So I do want to start out with a case, and in this particular case, you're either the caregiver or maybe the treating physician, and you get a call from the care facility, or maybe you are the care facility and you're calling the physician to talk about the problematic behavior. It's an 82-year-old with Alzheimer's disease that's moderate in severity. They've been at this adult care home for about 2 years, and you either tell the physician or the care provider that the patient is having problems, and something is needed to calm them down. So let's say that that's how it starts out. This patient's having problems. We need something to calm him down. Do you think that, I mean, how often does that happen, that this is the way you describe a behavior?
Our prescriber would say, "What are you talking about?
That's
You need to
good.
Tell me." Like that's, I don't know.
Perfect.
She
Yep.
would bite my head off if I did that.
Okay. And has anyone had a different experience where this might be enough to just say, this patient's having problems, we need something? If not, that's fantastic. So okay, so the person you're paging says, okay, well, what's the problem? Oh, he's agitated. Is that enough?
No.
No, agitation is definitely not enough. I think I went backwards. So yeah, agitation is not enough. So when someone tells me that a patient is agitated, I say, please be specific. Tell me more about what you mean by agitation. And agitation is probably one of the most commonly used descriptors for describing a patient's behavior. But there are so many inherent problems with the term agitation. It's not a specific term. It's not a diagnostic term. There is no universal definition, and it means something different to everyone. And the cause of that particular agitated behavior is often multifactorial. And in order to understand what factors might be contributing to that set of behaviors, you need to know more than just that the patient is agitated. And there are a wide range of particular behaviors that agitation gets used to describe, such as general restlessness, pacing, complaining, verbal repetitions, cursing, kicking, hitting, name calling. So really any problematic behavior might be perceived as agitation. So in describing a patient as agitated, it really doesn't it doesn't say much. The way that I like to approach agitation is to understand whether the behavior in question is either aggressive or non-aggressive, and whether it's physically aggressive or physically non-aggressive, or verbally aggressive or verbally non-aggressive. And I'll talk a little bit about each over the next couple of slides. What are physically aggressive behaviors? Hitting, biting, throwing. Yeah.
Many names.
Yeah.
Hair pulling is a favorite of ours.
What is?
Hair pulling.
Hair pulling. Yep. So knives. What? Oh, knives. Yeah, potentially.
Also like wrapping colics around their neck or trying to swallow things.
Yeah. So these are the really, really severe behaviors, the behaviors that make us all worry, and the behaviors that gets patients, sent from the care facility to the emergency room. They're the really problematic behaviors, and the ones that you guys described. They tend to occur in later stages of the illness. They tend to occur more commonly in men than in women. And they also tend to occur during times of close physical contact, so like with ADL care. And interestingly, they're more common in people who have a premorbid history of aggressive behavior. What about verbally aggressive behavior? I know I've got the answers up there, but what are some examples that you guys have encountered?
I'm gonna kill you.
Yep. What is it?
You're poison.
You're poison.
I had a woman yell, "You fucking bitch," like 20 times at me in a row yesterday.
Oh, man.
Yeah.
Yeah.
As I was walking away, I didn't even engage her.
Yep.
I was just like, oh, she's in a bad mood.
Yeah. Yeah, so they're hostile. It's hostile behavior. It's not physical, but it's verbal, and equally as problematic as physically aggressive behavior. So if you're describing a patient as agitated, think about describing the behavior. That agitated behavior is either verbally or physically aggressive, if there's an aggressive component to it. Non-aggressive behaviors, on the other hand, are not unsafe in and of themselves, but they are equally as problematic because they can be very distressing to the caregiver or to other patients in the facility. So what are the physically non-aggressive behaviors that you might encounter?
Walking around in your underwear with someone falling off.
Uh-huh. Yep. So sort of restless behavior.
Exposing yourself to others on purpose.
Yep.
Or maybe not on purpose, but laughing after their reaction.
Uh-huh.
They know what they're doing.
Yeah.
Okay.
Peeing in the corners.
Yep.
On the floor.
Yeah. Wandering is common, disrobing, I put it there, repeating gestures or movements. When you see these types of behaviors, you can categorize them as physically non-aggressive behaviors. And there's a counterpart to it, which are the verbally non-aggressive behaviors. These are the behaviors you see where the patient complains or repeats or calls out frequently or talks constantly. So again, not unsafe, but disquieting and potentially problematic.
Now, how long can they have those symptoms? My dad's been like that for 20-some years, so technically it's nothing new for me. But it's like he's 74 now, and I find out through his family members that he's been doing that since he was 20. So I mean, how long toward the end when they've always done it? Is it a symptom? Is it a symptom or a personality?
I mean, if he was doing it back in his 20s before he developed a dementia, it sounds to me like it may be more related to that. And it's become more frequent because he's not able to regulate himself as well as he could when he didn't have a dementia. So my expectation would be that behavior persists until he becomes less interactive and the dementia progresses. Would be my guess.
So if you were to use the FAST tool and to target symptoms, level 1 through level 7, would these symptoms be progressive or would they be in each level?
It varies from patient to patient, and the FAST criteria, we don't necessarily see patients progressing through stages 1 through 7 in that sequence. So again, it's very patient specific. But I would say that the physically aggressive behaviors we tend to see in the moderately severe patients. In the non-aggressive behaviors we tend to see, perhaps earlier on. Let's do another case. So you bring a patient into the clinic and you tell the physician or the caregiver, the healthcare provider, that the patient is having hallucinations. And more background on the patient: she's 75 years old. She has moderate Alzheimer's disease and she lives at home. What do you think about hallucinations? Is this an adequate description of a problematic behavior? And why isn't? You're shaking your head. Why isn't it adequate?
I think it should be determined if they're causing distress or not.
Okay.
The previous speaker had talked about a pleasant hallucination that her father had experienced. And sometimes people do have hallucinations that are not distressful.
Yeah. Okay.
And
Yep.
what is it, and how often does it happen, and is it auditory or visual?
Yeah.
Or
Is it religious?
Okay.
Are they reporting it to you, or are you observing them responding to internal stuff?
Uh-huh. Yep.
Is it keeping them from their activities of daily living or
Uh-huh.
enjoyment of other things?
Yep.
Is there a theme?
Uh-huh. So I would even go one step further and say, is it an actual hallucination or is it a delusion? Hallucinations are actually fairly uncommon in Alzheimer's disease. Visual hallucinations in particular, if they're abrupt in onset, might suggest something else like a delirium, or if it's been occurring insidiously with progression of the cognitive impairment, I might think of a different type of a dementing disorder like dementia with Lewy bodies. I want to know more about what is meant by hallucinations. Do they actually mean, false sensory input to the visual system or the auditory system, or do they mean a misbelief? And in Alzheimer's disease, we much more commonly see misbeliefs. And they're typically pretty simple, in comparison to delusions we see in psychiatric disorders like schizophrenia. And they're usually related to paranoia around losing something or forgetting where something was put and then thinking that it was stolen. And that's a very characteristic delusion that we see in Alzheimer's disease, and that's not a hallucination, so they're very different. And whenever I'm told, asked to treat a problematic behavior, again, I don't just stop at the chief complaint. I always want to know more about the behavior in question. So moving along the roadmap, once I've gotten a good sense of what the behavior is that I'm being asked to treat, I go further and I look at medical or environmental causes that might be contributing to the problematic behavior. And if they're present, I move on to treating those particular inciting factors. And while I'm doing this, I'm also doing a mental status exam, which I'll talk about as well. So before going to here or to here, I start here and move here. Does that make sense? So the environment, you had asked about the environment. You had said, is overstimulation a problem? Yes, overstimulation can be a problem. And what's meant by overstimulation? What is it?
Too many outings all in one week, too much going on.
Yep,
They're
too
good
much.
for 2 hours. When you're young, like us, we can have a full day, 10 hours doing stuff and dealing with people. They're good for maybe 2 hours, maybe 3 in a whole day.
Maybe you're overexerting them. What else?
Making gals all night, stuff like that.
Yep, waking them up at night during rounds. Maybe the TV is on and it's distracting and loud. Maybe the telephone is going. Maybe there are too many visitors. Sometimes mirrors are a problem if the patient doesn't recognize themselves in the mirror. Maybe pictures are distracting. I once was asked to treat a patient who was agitated, and the care facility was, they were doing construction. And every time the construction crew came through and made noise, the patient would get restless and unhappy. And I'm certainly not going to prescribe a medication to treat that when a more reasonable solution is to remove him, if possible, from the construction area. And that was possible to do, and the behaviors went away. On the other hand, understimulation can be a problem as well. And again, it's very patient specific. Some patients may do well in an environment where they're stimulated and not well in an environment where they're unstimulated. So what might constitute an understimulating environment? And I actually see this much more commonly than I do overstimulation. Sitting around, yep. Maybe the room is dark. They don't have, they're not seated near a window, so they're not getting any environmental cueing from the sunlight. Maybe it's very quiet. Compound that with, impaired hearing and impaired vision, and you've got this setup for a person who really isn't having any sensory stimulation, and it's kind of like they're floating around in space. And what do you do if you don't see and you don't hear? I mean, what's likely to happen?
Sleep.
Maybe sleep or panic or act out or yell. So I do consults at a nursing home where this is actually the biggest issue. I walk into a patient's room and the blinds are pulled and they're laying in bed, and maybe they're asleep, and I'm asked to see them because they're not sleeping at nighttime. Well, if they're getting 8 hours of sleep during the day, I don't expect them to sleep at night. So what would a reasonable intervention be? Get them up, open the blinds. The first thing I do when I go into a room in a nursing home is pull the blinds up if it's daytime. In unfamiliar environments can be a problem as well. How many patients have you treated who acted out in the first few days of admission to your facility? Have you guys experienced that? So, you know, making an environment comfortable and familiar can be useful, whether that's bringing personal items from home or having the family present daily in the first few days that they move into the facility. Those can be pretty helpful interventions when an unfamiliar environment is precipitating the behavioral problem. And now, in terms of medical precipitants of behavioral problems, you may have gotten more of this earlier, but one big factor that can make a person uncomfortable and restless is pain. And pain doesn't just mean musculoskeletal pain. It means pain from constipation, pain from urinary retention. It means hunger. It means thirst. You know, as reasoning and language skills begin to deteriorate with the progression of the dementia, how do people how do they then communicate behaviorally? So you've got a person who can't tell you that they're hurting or can't tell you that they have to use the restroom. How might they, you know, if they can't directly tell you, how might they indirectly tell you? Yeah, yeah. Yeah.
One thing I've wondered is if it is somebody who is nonverbal and the team suspects pain and they start treating for pain, it seems like to assess whether it's been successful is kind of a challenge because pain medications, so many are so sedating.
Mm-hmm.
So how do you tell whether, oh yes, pain intervention is what worked, or no, now they're just sedated and not acting out anymore? How do you distinguish that?
The first choice in pain medicine should be a medicine that isn't sedating. And do you know what that is? Yeah, acetaminophen. So if there are no contraindications, and usually there aren't, rather than using it PRN, I actually will have it scheduled, QID, and then I make an assessment based on how they respond to the acetaminophen. And there are some nonverbal cues that you can look at when trying to assess a person for pain who isn't able to communicate. So I always start with acetaminophen, which is non-sedating. And you can usually get a pretty good idea of whether it's helping or not. Yeah. Beyond just pain, sometimes infections, like from a urinary tract infection, can lead to an alteration in mental status. And certain medicines can cause changes in mental status as well. What are some problematic medicines that if you were to admit a patient to your facility and look at their medication list, what medicines would stand out to you as being like, wow, that could be a problem?
Ativan,
Yep.
Advil.
Yep.
Yeah.
Morphine. Yep, muscle relaxants. You know, common classes of medicines that are problematic are like the Ativans and the Valiums, so the benzodiazepine medications are usually should be avoided in older patients. Opiate medicines should be avoided when possible. Potentially Ambien, anticholinergic medications, so like over-the-counter antihistamines, muscle relaxers are all potentially problematic meds. So it is useful if you are giving a report to a healthcare provider over the phone about a problematic behavior that you go over the updated medication list with them so that they can assess, or you can also assess for the presence of potentially problematic medications. In terms of the medical workup, you know, a basic workup for all patients with altered mental status includes some pretty basic stuff like a blood count, a chemistry panel, and a thyroid function. A B12 if it hasn't been done recently, and a urinalysis. And, you know, that's not every time the patient has a problematic behavior, but perhaps part of the initial workup. So you might find the healthcare provider asking for a urine sample to send off for a urinalysis, or ordering these particular labs. And you know, we sometimes will order neuroimaging, but only if it's indicated. So if there's a new neurologic finding, so if accompanying that change in behavior, you're seeing, you know, weakness on one side of the body or slurred speech, then you know, neuroimaging might be useful. Or if the patient's fallen and they sustained a head injury, particularly if they're on any blood thinners, imaging could be really useful. Now, what about the mental status exam? So as a psychiatrist, this is sort of my, you know, I sort of do a mental status exam multiple times a day. How familiar are you guys with a mental status exam and the elements of the mental status exam? So some nodding. So Nodding of the head. So the first thing I do is I look at the patient, and that's sort of the general appearance of the patient. I want to know, how well groomed are they, and and folks can be not well groomed for a number of reasons, maybe neglect, or maybe they won't allow ADL care to be provided. I want to know about their weight. Has there been a recent change in their weight that might suggest, that they're not eating, or that there's something else going on with them preventing them from gaining weight? I want to know if they appear to be in pain. I want to listen to their speech. I want to look at their affect. So do they look anxious? Do they look sad? Do they look angry? And I try to assess their thought process, which is assessed by listening to what they say. And depending on the stage of the dementia that they may be in, you may get a linear, organized thought process, or it may be disorganized and hard to follow. But the most important thing is when it comes to Alzheimer's disease, these things don't change overnight. These are gradual changes. So what I want to know is how far off is this from their baseline? If they were able to speak in a coherent and linear manner yesterday, but today they're angry and upset and their speech is slurred, or they've got word salad, then that sends me down a different pathway than prescribing a medication to address the problematic behavior. Thought content refers to, the content of what they're saying. Are you picking up on delusions? Are they reporting hallucinations? Is the content of their thought just sort of empty and without meaning, which is common in later stages of Alzheimer's disease? But again, most importantly, how far is this from their baseline? What are they typically like? And what about cognition? What is cognition?
Thoughts paired with feelings.
What is it?
Thoughts paired with feelings.
Say it, sorry.
Oh, like if you have a feeling and then you attach a thought to it, that's a cognition.
Okay. When in the context of a mental status exam, cognition, refers to what might it refer to? I'm just kind of curious to hear what other
It's like
people.
thought content.
Yeah, so we glean our assessment of a person's cognition from their thought content, but it's really looking at what are their cognitive processes like? Are they oriented? Their functional status, what's their memory like?
Are they understanding what you're saying?
Are they understanding? Yep, that's right. And there are several 30-point mental status exams that we can use to objectively quantify how a person is doing in terms of their cognition. And has anyone ever given a 30-point mental status exam? Which ones have you guys given? The
I love
MOCA
the
is one.
MOCA, yeah.
Yes.
But also the slums.
The slums is commonly
MMSE.
used. The Folstein Mini Mental State Exam. And these are tests of cognition, and they really just sort of look at how a person's cognitive processes are doing across several sort of common cognitive domains. And we expect a person who is not demented to score 28, 29, 30 out of 30 on these tests of cognition. Patients who are mildly demented typically score in the low 20s. Patients who are moderately demented typically score in the teens, and patients who are experiencing pretty advanced dementia often score 14 or below, or 12 or below. But the most important thing to consider when you're doing this mental status exam is when it comes to Alzheimer's disease, we typically see a 2 to 3 point decline per year. So if a person scores 23 in 2000, score of 23 out of 30 in 2013, and I'm seeing them 1 year later, and they've got significant behavioral problems, and I give them the MMSE, and they're cooperative with the exam, but they score a 9 out of 30, my mind isn't thinking, well, the Alzheimer's disease is progressing. My mind is thinking, well, something is making this much worse, because this person shouldn't have dropped so substantially in terms of their performance on that particular mental status exam. So this can be very, very useful. And if you have time to do it, it's great. But if not, doing some type of an assessment of their thinking and memory is useful.
Is that something that most internal medicine doctors would think about doing?
It's variable. Hopefully, yes. Yeah.
What is the progression rate for early onset versus older onset of dementia? Do you notice any differences?
Earlier onset dementias typically progress slightly faster than later onset dementias. Yeah. So really, really useful. Try to familiarize yourself with one of these 3 commonly utilized 30-point mini mental status exams because it can be really useful. We'll do another case, 78-year-old who has Parkinson's disease dementia. So this isn't an Alzheimer's dementia, it's a different type of dementia. He, and it's a patient I saw, was referred to me because of, agitation was the reason for the referral. In gathering the history from the care provider who provided me with the history, I was told that he moved to this new care facility. He tries to get up and out of the wheelchair, and in doing so, he falls. So the care providers rush at him to stop him from getting up, and guess what he does? He hits them. He sort of fights and hits to stop them. And when I saw him on mental status exam, so in terms of the general appearance, he looked pretty well groomed, pretty well nourished. He was very cooperative with the exam. He was bradykinetic, which was consistent with his Parkinson's disease, which means he sort of moved very slowly. He didn't talk much. And in terms of thought content, the caregiver told me that he's having visual hallucinations. How might you approach this particular case? What are your thoughts on what you might do?
I would tell them to stop rushing him.
Yep. So you're picking up on that sort of environmental trigger for the for the agitation, which is why they wanted him seen.
Find out why he doesn't want to be in the wheelchair.
Yep. Why is he getting up in the first place?
Maybe he needs a new cushion or something.
Yep. Maybe he's uncomfortable. Yes. And that's actually very similar to the approach that I took. So what's going on in the environment? Why does he want to get up? Is something making him uncomfortable? Is he in pain? Does he need to toilet? And actually what I found out was he did not have much stimulation at all. He was really just kind of put in this chair and sat in front of a TV. And whenever he would get up, which was pretty frequently, the caregivers would rush at him, and he would strike out, but it was really sort of a confused. It was a reflexive striking out. So the plan that we developed was to keep him occupied, to walk him frequently, and to approach him slowly and inquire about his needs. And that actually worked. So there was no need to prescribe a medication, though that was what the caregiver wanted. Their expectation was that this patient would get a medication to treat this problematic behavior.
Relationship building, how involved is that with folks with dementia? I mean, you could have known somebody for 10 years and then all of a sudden dementia is on set and it starts happening, and then they just may not know who you are.
Yeah.
So is relationship a key thing, or does it matter?
It can be. I think consistency is extremely important, and there may be lucid moments where something sparks and they recognize the loved one. So consistency in relationships are very important. So moving on to non-pharmacological approaches to managing behaviors. So you've decided that the environment's okay, there's no medical cause for the person's behavior. Do you then jump to treating with the medication, or do you then take a non-pharmacological approach? And I've highlighted my approach. Mine is to take a non-pharmacological approach first. And do you agree or do you disagree? Absolutely. Okay. Yeah. So when possible, I start here. The first thing I do is get a sense of what their daily routine is like. And what I often find is that there is no daily routine. So we work on developing a structured daily routine to keep this person busy. And that's where consistency and predictability does become very important. If it's available, recreational therapy, so at the nursing home where I work, that is available. I try to get a recreational therapist to work with the patient, but it doesn't have to be a recreational therapist. It can be anyone that's able to help to keep the patient busy and occupied. I also want to make sure that there's some physical activity that's happening during the day and that the patient isn't sleeping all day long, because when there is no physical activity and the patient is sleeping all day long, they're not sleeping at night. And that's a problem because the caregiver wants to sleep at night and the other patients in the facility often want to sleep at night. When it comes to sleep, I want to make sure that the environment is comfortable and that it's quiet, so it's not noisy. which, sometimes those bedtime checks can be very noisy. So if you can do it quietly to avoid disrupting their sleep, it can be really helpful. Limiting evening fluid intake. So after 6 p.m., no fluids. That helps to reduce the need to get up and use the bathroom. Scheduled bladder emptying right before bedtime so that they don't wake up at midnight to empty their bladder. Bright light during the day and darkness at night. That sounds obvious, but it never happens unless I specify that this needs to happen. Even when I specify it and I go to see the patient for follow-up, guess what I'm doing? Opening the blinds. So that is extremely important. That they're, that they are exposed to light during the day. And this may seem obvious, but again, it's not. Certain things can be stimulating and not be conducive to a good night's sleep. Caffeine, alcohol, nicotine, and caffeine can be found in tea and coffee, obviously, and chocolate. There are a lot of things that have caffeine in them that you might think about. So be aware of what your loved one or the person you're taking care of is eating before bedtime or drinking before bedtime. When it comes to ADL care, which is where we often see the physically aggressive behaviors, bathing, make sure the bathroom's safe, that there aren't things that they can grab like a knife. Someone had mentioned knives. That there's something they could grab and use as a potential weapon. That the water temperature is comfortable. Again, it seems very obvious, but I'm always surprised when I find that these things aren't being considered. That the patient doesn't or the person doesn't feel rushed. And consider washing the hair last because it's one of the more sensitive parts of the body. And if a person doesn't understand what's happening to them and you're trying to shampoo or wash their hair, they might strike out. And when all else fails, a towel bath is better than no bath at all. When it comes to dressing, limit choices. Have the clothing prepared and laid out. Large clothing with soft, stretchy fabric can be really nice, or rather than a zipper and a button, a drawstring can help you to get that off more easily. And Velcro shoes are much easier to secure on a person's foot than shoes with ties. When it comes to eating, maintaining a regular mealtime can be useful. Avoiding distractions during mealtime, checking food temperature, using finger foods as opposed to foods that require utensils, and using foods that are very sweet and palatable and tasty to the person may help them to eat. Do you guys have any thoughts on those particular ADLs and what type of care to deliver when you're doing it?
So how important is it to be consistent maintaining a regular mealtime? I know, like say my 2-year-old son eats when he's hungry. Would it be the same with a person with dementia, that they're going to eat when they're hungry? Or should you say, at 9 o'clock and at 12 o'clock and at 5 o'clock offer that bowl of finger food on a regular basis?
In the earlier stages of the disease, I think the scheduled meal times are more useful, but in the later stages, when you just want to get some nutrition in them, I would go with, eat when they're ready to eat, offer them food when they're ready to eat. But what you'll find is that, as the disease progresses, that they're just not interested in food. And that's where using foods that are easy for them to eat or foods that are very sweet and palatable can be useful.
So what about toileting if they're like already in a TENS and making them go sit on the toilet usually ends up in a violent interaction?
Yeah.
How important is that to trying to keep them using the toilet or just checking their TENS or
it really becomes this risk-benefit ratio, and is the payoff going to be enough to continue getting them to the toilet, or do you just check the TENS or check the depends and get them cleaned up after they've used sort of soil themselves? Yeah. It really, again, is very patient-specific, and you've got to weigh that risk and benefit ratio with each patient.
Also, just knowing the context. Like, we had a patient who she was very pleasant, but when it came time for a bath, she would get really freaked out, and I eventually obtained a bunch of her old records and found out that her husband had tried to drown her in the bathtub.
Wow.
Oh my gosh. So we switched her to showers on the other unit, and it wasn't a problem.
Yep, wow. That's great. It's a wonderful individualized approach to care. That's fantastic. What about wandering? How much of a problem is that for you guys? It's a problem for some, not for others. When it happens, make sure that they are having adequate daily physical activity, because wandering just may be this attempt on the person's part to move. If they do wander, create safe wandering paths, places where they can walk safely. Remove reminders of leaving. So this is kind of funny, but it actually works. When a person sees, a coat hanging by a door, they're much more likely to go to the coat, put it on, and try to leave than if that coat wasn't there. So if there are reminders of leaving, umbrellas, coat, shoes, just move them out of the way. And if all else fails, alarms or bells at door exits can be helpful to maintain safety. And of course, patients should, if they are wandering risks, have ID bracelets on in the event that they do make their way out of a safe environment. They can get brought back. With incontinence, scheduled voiding can be really helpful. So, every 3 hours, get them to the toilet. Look for nonverbal cues. Are they pacing because they have to use the bathroom? If they are, take them to the bathroom and see if they go. Oftentimes, people forget where the bathroom is, or they can't find it. So signs by the bathroom door. There was one nurse that came up with this idea of putting this bright pink sign. It was like a bright pink circle next to the bathroom, so that this particular patient always knew where to go when he had to use the bathroom. And I thought that was pretty creative and pretty useful. And make sure obstacles are cleared and the path to the bathroom is nice and clear and easy for the person to get to. And what about delusion? So let's say you've got this person that says, let's say their spouse is deceased, but they say, my husband is coming to get me. My husband's coming to get me. What do you do with that?
Say pretty much. I say you can sit right here and visit with me, and you can see the door when he gets here. You can see him and go with him.
Yeah, that's a good
approach.
approach.
Distract her with something else.
Yep, distraction is extremely useful. So let's say the person says, people are coming to my room at nighttime, coming in and they're stealing things. What do you say to that? What was it?
Well, we can say, well, we'll have security check that out. We'll have, to make sure security sees who comes in and out of your room.
Yeah, we'll do everything we can to make sure that you're safe at nighttime, as opposed to, no one's coming into your room, or challenging the particular delusion. When that delusion gets challenged, what typically ends up happening? A fight, an argument ensues. So I try never to challenge a delusion, but only to roll with the punches. Music therapy, bright light therapy, aromatherapy, and pet therapy. Medical literature is mixed in terms of how effective these interventions are. However, they are pretty easy to deliver. There is very low risk of harm, and I think that they're always worth trying. Have you guys tried this or had any luck with it? Yeah.
Excuse me, can I ask another question
Yeah.
about delusions?
Yeah.
This is from personal, my dad, with, he wakes up regularly just saying he has to go to a meeting. He has to go now to a meeting. And, he's not mobile, he needs a wheelchair. And, so we've had to really, let him know that it was a dream, that he really didn't need to be in a meeting, that he woke up having had a very vivid dream. But it continues, and there isn't a way, if it's needing to go somewhere. Do you have any suggestions for
How
that?
long does he sort of maintain the desire to go to the meeting?
For a good hour at a time.
So the way I might approach that is say, before you can go, let's make sure you've gotten your shower, and let's make sure you've gotten breakfast, and I would focus on those things during that hour where he may be talking about wanting to leave.
And hopefully he's forgotten.
Yeah,
over
and
time.
typically, often a person will end up forgetting about it. Yeah, but I wouldn't say, no, you don't have a meeting to go to, you don't work anymore, because that is really common, where a person may have had a skilled trade or a very set routine, and as their dementia progresses, they go back to wanting to do those things. And rather than saying, you don't do it anymore, sort of rolling with it. Yeah, yeah.
Is there a way you could bring his work or a synthesis of his work in? Like, we had a guy who was a mechanic. So we just brought in some nuts and bolts one day because he was taking apart our doors and, all sorts of stuff. So we just brought in a bunch of stuff, and he fiddles with it nonstop.
One
And
of the
leaves the doors
facilities I go
alone.
to, they actually did set up a workspace because they had a gentleman who kept saying, I've got to go to work.
Yeah.
And they found an old typewriter, they found an old phone.
Yep, that's great.
And they put files together for him, and
Yep.
he does go there. He doesn't spend that much time, but he finds it reassuring.
That's
Yep.
interesting.
Yeah.
You can tell them in the meeting.
Two small anecdotes. At one of my previous jobs, the director of our agency, his father was in the throes of Alzheimer's, and he was a hardworking man all of his life. And he brought his dad into work with him every day, and his dad would be dressed very neatly and nicely, and he put him up in a little workstation, and he would make lists of words. He'd say, Dad, could you copy? Literally, it was make work, but his dad was so
Yeah.
happy and would take breaks and would go home tired and sleep well at night. But we also, I was working with a family caregiver, and I'm aware that her husband was real fixated with needing to go to the meeting, and she would take her cell phone, call the house phone, pick up the phone and say, oh honey, the meeting has been canceled today, you don't need to worry
Yeah.
about it.
That's
You don't
another
need to
good
go."
approach.
So
there you go.
it's that joining
Yeah.
them on the journey and finding a way to, because really to create more work for yourself by having to have breakfast and a shower and,
Yeah.
you know, in a way, it's a way to divert that activity totally if you call and cancel the meeting. So
Yeah,
that works.
that's a fantastic
Very
approach.
good.
Yeah, anecdotes are appreciated, so
Yeah.
anytime you have one, just say it.
Lying's okay.
What's that?
Lying can be okay.
Yeah, I mean, the alternative is to, often leads to an argument. Yeah. So moving on to drug therapy, and I'll try to do this pretty quickly because I know that most of you in the audience are not folks who would be prescribing medications, but I still think it's useful for you to know the commonly prescribed medications and what some side effects are to look out for. And I want you to know and to keep in mind that there are no FDA-approved medications for treating behavioral symptoms in dementia, and there is no magic bullet. So there's no one-size-fits-all prescription medication that's going to make a behavior better, and that often the behaviors that we're trying to treat are multifactorial in etiology, which makes the no magic bullet approach even more important to remember.
You might just responding though to the research out there that says cognitive enhancers, or the use of two of them, can help prevent behaviors.
Yeah, we'll talk about that.
Okay.
Yeah, we'll talk about that. And as a general rule of thumb, we always like to start at a low dose of a medication and work our way up slowly to avoid the risk of side effects. The patients who we're treating have older bodies, and their older bodies render them more susceptible to side effects of the medicines that we prescribe. And when a medicine is not effective, we should consider stopping the medication as opposed to just adding on. And when a patient's doing well, so let's say you've got 6 months of good behavior, it's important to try to remove some of those medicines slowly and see how they do. Treating behavioral symptoms in dementia is a moving target, and as the brain changes due to the illness, the need for medications often starts to go away. There are certain behaviors that just don't get better with medications. Calling out, repetition and vocalizations, they just typically don't get better with medications. Wandering and exit seeking doesn't get better with medications. Disrobing doesn't get better with medications. Hoarding usually doesn't. Inappropriate voiding doesn't. So when you are working with someone who has these types of behaviors, do keep in mind that asking for a medication may not be the best way to approach it. I'm going to sort of skip over this in the interest of time and talk quickly about the symptom-oriented approach. There are so many medicines that we can prescribe for behavioral symptoms in dementia. How do we choose what medicines to prescribe? The approach that I take is to look for a pattern of the person's behavior that we might see in a drug-responsive psychiatric condition. So if the person looks very depressed, if they're crying, they're tearful, the first medicine I'll start with is an antidepressant. If they look very anxious, very restless, very worked up, I'll also try an antidepressant first. If they are psychotic and they're suspicious and they're hitting and they're angry, I'll typically try an antipsychotic medication. If they appear impulsive, hypersexual, accelerated, I might try a mood stabilizing medication like Depakote. And this is in your slide, so you can always reference it. There are going to be patients for whom their behaviors don't fit into one of those nice, neat boxes. And there was an expert consensus panel that put together some recommendations back in 1998 that I think are still helpful now. For sort of mildly problematic behavior, using trazodone as a PRN can be oftentimes quite helpful. If the behaviors are persistent and happening day to day, but they're pretty mild, they're not aggressive or dangerous, using a memory-enhancing medication like a cholinesterase inhibitor, an antidepressant, or scheduling trazodone can be useful. And when the behavior is aggressive and it's dangerous and it's unsafe, these experts recommended the use of an antipsychotic medication. So I'm going to go over that. These are the,
What do you do typically for patients that have the psychotic episodes on a consistent basis but don't take medicine, refuse to take medicine?
Yeah, that can be really challenging. Any anecdotes?
This whole group has been dealing with one person for the last year that's been progressively getting worse, and she's gone from seeing terrorists and being just afraid of them in her mind to everybody's out to get her and we're all going to try to kill her, or she wants to kill herself. She will not take any sort of medicine.
Why won't she take medicine?
She refuses.
She's also schizophrenic and developmentally disabled. Yeah.
Does she have a guardian?
Yes.
What have you guys talked about?
We're just now, I guess, in the stages of trying to get some help for her, but it's been going on for so long, and I was just wondering what you would typically lean towards for somebody.
In terms of a medication, or in terms of how to get them the medication?
Right, or both, or how to deal with them without dealing with the medications that they won't take. I mean, is there?
Very aggressive. This is every day.
And is the problematic behavior dementia related, or is it due to the schizophrenia?
Both.
It's both. It's,
Yeah.
I mean, like you can see the natural. I've dealt with a lot of dementia and Alzheimer's. I've seen the natural progression of that disorder, and with the combination of the schizophrenia and the other mental illnesses that she has, it's like they're combining to make this one teeny tiny little package of aggression.
Yeah. You know, oftentimes what I'll do in those extreme circumstances is get permission from the guardian to give medicines and food.
And food.
But
Yeah.
if it has any kind of taste at all, she's really good at knowing it and will not take it.
Yeah. I mean, you know, ice cream and pudding are pretty flavorful and can cover the flavor. You know, but there are a lot of ethical issues at play when you do something like this, and so I try to have as detailed of a discussion with the guardian as I can about this approach.
I worked with people with psychosis for years, and they didn't have dementia, so that is a challenge.
Yeah.
But a lot of times, my approach, if paranoia was on board, was to say, your body is under a lot of stress because of all the fear that you're experiencing, and maybe we can help your fear come down. And a lot of times, if I had the relationship established, that worked.
Right.
If it was helping people understand that they didn't have to be terrified all the time, forget whether what they were thinking was accurate or not, and leave that out. That was, but I don't know how far along I guess she is in her dementia.
You know, so that is a useful approach, is to find a symptom that bothers that person. So it might be, I can't sleep at night, or I feel very anxious, and to offer a medication that can help with that, but can also help to treat the underlying problematic behavior. That's a pretty good approach. So we're out of time, unfortunately, but you do have my slides that you can reference for the medication piece, but I think we had a nice, fruitful discussion about the non-pharmacological approaches. Yeah.